So I'll be talking to you about Natasol, the enhanced drug delivery in fungal keratitis, and there are no financial disclosures. And when you use topical natamycin 5% in a case of fusarium keratitis, uh, this is how the response should be, but it is not always like this. And basically 5% natamycin is the mainstay for any case of fungal keratitis, but there are limitations in the form of commercially available preparations, poor ocular penetration, poor bioavailability and toxicity. So the indications, we sometimes do the targeted drug delivery in these cases, which includes intracameral antifungals, such as this, which causes the resolution of the ulcer. And sometimes also the intrastromal injections are required because the penetration of the natamycin is not that great. We did publish the TST protocol, or the topical systemic targeted therapy protocol in fungal keratitis. And if the fungal keratitis is not responding for 4 weeks, then one can give either intrastromal, intracameral injections, or both, depending upon where the exudates are. Now, what we've been working on is natamycin 5%. Natamycin is water soluble, insoluble, has 5% suspension. So also because it is insoluble, it causes local irritation and excessive tear secretion. And tear dilution also leads to the drug loss. Suspension formulation should be mixed properly before instillation. Natasol or natamycin 1% is a soluble form of natamycin, and it is characterized, basically characterization of the complex natamycin is done and is performed by the Fourier transform infrared spectroscopy and differential scanning calorimetry, and it is tested for stability in conditions related to patient use in white light at room temperature, dark room at 25 degrees centigrade, and by opening and closing the vial once a day at 4 degrees centigrade. So we did single and multi-dose transcorneal permeation studies of Natasol 1%, which was soluble form, versus 5%, which was suspension in albino rabbits. And sterile, unpreserved, ready-to-use water-soluble natamycin for intrastromal injection was developed using the ARVO guidelines. It is protected against the degradation under various stability circumstances. This is what we found out, and also it prevents natamycin photodegradation as well. This Natasol 1% we used as topical drops and also used as intrastromal formulation. And we have patented this drug. So just looking at the FT infrared spectroscopy, this is for natamycin and this is for polymer. So when you combine natamycin with polymer, this is what you get. And again, if you look at the representative scanning electron microscopy, the polymer looks something like this, and the pure drug is like this. And the combined, when it gets when you have the Natasol complex, then this is what is obtained. So in terms of drops, Natasol is like clear solution, slightly yellowish in color, but natamite or suspension is not a clear solution, but it is a suspension. And I would like to acknowledge Dr. Vel Pandyan from Ocular Pharmacy, who works on it. So we did single-dose transcorneal permeation studies and multi-dose kinetics. The single-dose kinetics did show, if you compare Natasol with natamycin, that the 1 hour permeation was higher as compared to the suspension. And again, this plateaus, but at all points in time, it is higher than the natamycin suspension when we compare it with the natamycin suspension. In steady state pharmacokinetics after hourly and 2 hourly dosing of multi-dose kinetics also confirmed the same. So this has been now put into small tubes, and basically what we require is we have natamycin and cyclodextrin mixed in water. The supernatant is separated and lyophilized, and required amount is mixed in water and sterilized by 0.22 microns filter. And the final formulation is subjected to bacteriological and fungal culture tests before use, and the final sterile drug with osmolarity of 290 milliosmoles was used. The formulation was dispensed in ampules such as this, and we evaluated the role of Natasol in 60 patients. Group 1 had 20. Each of them had 20 patients. In one group, we put only natamycin. In the other group, topical natamycin and voriconazole. And the third group, topical Natasol. And the follow-up that was done was at day 3, 1 week, 1 month, 2 months, and 3 months. So if you see the visual acuity, in terms of visual acuity, there was no difference found between the 3 groups. In terms of the infiltrate size, it was comparable between the groups. There was a significant difference in the rate of healing between the 3 groups, and the patients where Natasol was used was found to epithelize much faster. And if you look at the anterior segment OCT pictures of those also, we found that the Natasol had treated, this is the Natasol treated group, where the deeper ulcers could also be treated. This is the combined group, and this is topical gentamicin, and these are just representative pictures. So we did publish the results of the same, that is the surgical outcomes with intrastromal gentamicin, which was also used. Mean age of the patient was 40 years, and organism isolated was aspergillosis and fusarium both. And the cure rate was very high, to the tune of 95%, which is not expected in cases of fungal keratitis. Subsequently, we also did a randomized control study where we compared the intrastromal injections of voriconazole, amphotericin B, and gentamicin in cases of recalcitrant fungal keratitis, and 60 eyes of 60 patients were used for this. And again, in one group we gave intrastromal voriconazole, in the other group intrastromal amphotericin B, and the third group intrastromal gentamicin. But the adjuvant therapy was continued in all of these groups. Again, these were evaluated in terms of the baseline parameters. All of them were well matched, and the fungal organisms were also, there was no difference between the 3 groups, and hypopion also height was matched. There was a reduction in height of the hypopion, and there was no difference in the 3 groups. Repeat intrastromal injections were given in all the 3 groups, and again, this was not found to be statistically significant. The height of the hypopion decreased significantly in all the 3 groups, and this is one case of intrastromal gentamicin, day 1, and this is how it resolved at day 14. Then the reduction in the height of hypopion was significantly better in cases of Natasol as compared to voriconazole. And again, we found that the percentage of high eyes or the response was found to be similar with Natasol, where Natasol was used. The scar size, we did not find any difference in the 3 groups, and also did not find any difference in the 3 groups in terms of vascularization, whether it was superficial or deep, or in terms of the quadrants of vascularization. What we found was that the amphotericin B group was the group where vascularization was significantly more as compared to the Natasol group and as compared to the combined therapy. Sorry. So this is another case of intrastromal voriconazole which was given. Notice here the lesion is in the posterior part, but at 6 months it does heal. This is another case where intrastromal voriconazole was used in the same cohort. And this is where intrastromal amphotericin B was used in the same cohort. This is again a case where intrastromal Natasol was used, and yet another one where it was used at 6 months. This is again, these are again the cases from the same cohort where intrastromal Natasol, that means the soluble form of gentamicin, was used. This was fusarium keratitis. Again, this resolved on therapy with intrastromal Natasol. So this is just to show the representative picture. So as far as the healing is concerned, it was fastest when we used the Natasol or systemic or soluble gentamicin. And in those cases where amphotericin B was used, there was marked vascularization as compared to the other 2 groups. So we conclude that novice gentamicin inclusion complex enabled formulation holds a promising role and useful adjunct to standard therapy in management of recalcitrant fungal keratitis, which means that it can only complement it, you cannot use it standalone. Then regional differences in microbiological profile should be considered before prescribing them, and we do require a longer term follow-up and larger numbers to validate the current results. This is our publication in Survey of Ophthalmology, and this is in Ocular Surface. I would like to acknowledge the people who worked on these 2 studies, and thank you very much for your kind attention.
Thank you very much, Professor Sharma. Any questions? Yeah.
So, unfortunately, the antifungal drugs are under rate contract, and so they do not, the companies cannot make too much of revenue out of it. We talked to 2 companies who'd refused, but there's a third one. I think the third company should be willing to take it.
Okay. I have a question about the formulation. So you just mix with the simple mixing, the natamycin with the polymer, or there's a chemical reaction to link up the molecules?
I think there is a chemical reaction to link up both of the polymer as well as natamycin. And this is done in our ocular pharmacy lab. So I wouldn't know the details by our ocular pharmacologist, but it is not simple mixing.
Okay, yeah. Thank you. Yeah, beautiful work. Thank you.